going to start the meeting. I've got a note here saying that recording has started, Paul.
Correct. Thank you, Chair.
So good morning, everybody. Thank you for attending today's meeting, special meeting, arising out of some issues, some concerns we had regarding the CCG's arrangements that we were given at our last meeting. So first of all, apologies. I've got Councillor Jens and Condaka.
Chair, an additional apology this morning from Councillor Kate Rolfe.
Sorry?
Councillor Kate Rolfe has tendered apologies this morning,
okay.
Chair.
Kate, yeah, thank you. Next item, any disclosures of pecuniary or non-pecuniary interest, please? Thank you, Joe. That is most definite of you. Okay, we go on to my announcements, which really is no more than welcoming our guests. Would particularly like to welcome Councillor Joe Clifford from Coventry Council, and Vicky Castry. Hope all is well with you, Joe, and good to see you again. From the CCGs, I think I've seen Anna there, Jenny Northcott, Adrian Stokes, Rose Unwins, and Jill Entwistle.
No, Jill's not joining us today.
She's not?
No, unfortunately.
Okay.
She's on leave.
That's fine. Thank you, Anna. We've also got David Eltringham of the North Warwickshire, of Warwickshire North Place Executive.
Good morning.
Good morning, David. Thank you very much. And I'm not sure whether I've said, yes, Chris Bain, I think is online with us. So welcome to you, Chris. Other than that, as it's a special meeting, I don't have anything else to report. So we're going quickly on. Public speaking, I don't think we have any, Paul.
No, Chair, none has been received.
Okay, so we're going straight on to the agenda item, the future of health commissioning in Coventry and Warwickshire. Now, Anna, I'm thinking that David Eltringham is going to start. Is that right or not?
No, I'm going to start and then hand over to David.
Yeah. Okay, away you go, Anna.
Thank you.
Just share screen.
Thank you, Rose. So, morning, everyone. I think I've probably met all of you, but there's certainly some names down the side that I'm not familiar with. So for those of you who don't know me, I'm Anna Hargrave and I'm the Chief Strategy Officer for South Warwickshire CCG. So at the last meeting, there were lots of questions you raised about the benefit of merger and in particular how Place would work. And there was lots of questions about how we would maintain that local focus, which is why we've asked David and Jenny to join us today, because what they'll be able to do is bring Place to life. And I know many of you are already involved in your respective places. But for those of you who aren't, I accept it's probably a difficult thing to get your head around. It's very different to how we would be working before. So hopefully David and Jenny will be able to bring it to life for you. Before we do that, though, I just thought it might be worth a recap, because very conscious that we've been talking about this for probably 2, if not 3 years in some guise or another, albeit merger is a more recent conversation, but the rationale behind it and the move towards integrated care systems has been something that we've been talking about for a little while. So I'm just going to give a quick recap on the story so far before I hand over to David. So next slide, please, Rose. So I thought it might be useful to just recap what our role as a clinical commissioner is. And I think it's really important to say at this point is that We don't deliver frontline services. We have staff who work very closely with the frontline and they provide a valuable support to our frontline workers. But we don't actually deliver services ourselves. We are the purchasers of services. And I know last time there was some concern about how a merger of the CCGs might start affecting access to clinics, change of location and so on. That is absolutely not what we are about. We are the planners and purchasers of healthcare services. So just wanted to provide that assurance for you. But in essence, we are the people who look at our population, understand what the needs are and determine how we best meet those needs, working with our stakeholders, in particularly the local authorities, in determining how we buy services in order for our population's needs to be met. And then we place contracts and hold our providers to account through those contracts, working collaboratively with them to work through areas where we need to improve performance and so on. So that is our role as a clinical commissioner. Next slide, please, Rose. So going back a couple of years now, and it was really outlined in the NHS long-term plan as a real direction of travel, and one that we were being expected to work towards at the beginning of 2019, was the concept of integrated care systems. And integrated care systems are in essence how we bring together different parts of our system to best meet the needs of our local population. And I think many of you will have probably been around enough to know that in the NHS we tend to flip between big and small, and the truth is that there is no one size is best for everything. There are downsides and upsides to kind of smaller CCGs, bigger CCGs and so on. But actually what this offers to us in terms of an integrated care system is in essence the best of all worlds. So at the very smallest level of kind of planning and service delivery, we've got primary care networks, and they're focused on populations of around 50,000. So that's very much bringing our GPs in, working with other providers and indeed the district councils as well, to think about what do services look like at that very local level of about 50,000 people. And then place, which is obviously the area that we wanted to focus on today, is very much around that population that's about 250 to 500,000. And actually, that's the footprint that the CCGs are working on at the moment. So we very much want to hold on to the benefits that we've been able to gain through the CCGs of local clinical leadership, working with our district councils and other partners to meet the needs of our local population. However, in the integrated care system, there's that piece that needs to be done at that bigger footprint level, which is about 1 million. And actually, as the 3 CCGs, we do serve just shy of 1 million people. And actually, what we're trying to do here is actually how do we bring our expertise and commissioning voice together over that bigger footprint. And actually things like stroke are a good example where we do need to work on that bigger footprint, and it would be much easier if we were one CCG, but it's recognising that those type of activities are really the minority. We say it's 20%, kind of Pareto principle. In reality, it's probably a lot less in some circumstances, and certainly, we have a debate, is it more like 90-10, and these are just examples, but it's really recognising that as 3 CCGs, we're not necessarily serving our population well when we are trying to do those big pieces and we're all working separately. So this is about how do we get the benefit of that larger CCG whilst remaining focused on place and keeping the benefits that we've had through the CCGs. And obviously a single CCG working with other larger CCGs across the region as well would be more effective in terms of commissioning voice from Coventry and Warwickshire going into a bigger footprint as well. Next slide, please. So why merge? So this has been, in terms of the integrated care system and the long-term plan, very much pushed us towards a single commissioner for an ICS. and that's engagement that we did last May. So we did a number of stakeholder events during May in 2019, where we asked people what the benefits would be of a different configuration of CCGs, whether we work more closely together or indeed went for a merger. And the consensus from our stakeholders was very much that merger was the best option. They felt that it gave us the best opportunity to develop place, because actually the way that we can organise ourselves from a workforce perspective would make us much more efficient, and that we could take a whole view of the population's needs across Coventry and Warwickshire, as well as a focus on place. It would lead to faster, more efficient decision making, which goes back to it's only one CCG that's making the decision rather than three. It would reduce our savings on running meetings, our governing body costs and so on, which ultimately can be directed back to services. So we can put that into our commissioning budget. So any money that we save on our running costs can be directed towards actual services that we buy for our population. A bigger CCG would also make it easier to recruit and retain the best staff, and that we would be able to do more to increase the health and well-being of our staff, but also it would give us also new opportunities for funding. On many occasions here we've talked about things like Section 106 and so on. A single consistent approach across the CCGs with one team becoming in essence experts in subjects like that would actually serve us all much better than the way that we are working at the moment. So there's some of the reasons why our stakeholders felt that merger was a preferred option for the system. But obviously we then needed to consider that and talk to our GP members about that. So next slide, please, Rose. So as this slide demonstrates, so we did that engagement, and not only did we engage our stakeholders in terms of our external stakeholders, we also engaged with our staff as well, who also felt that actually there was huge efficiencies and opportunities to do things better by working as a single organisation. We then spent time talking to our GP members from the three clinical commissioning groups, and they all voted in favour for a merger as well. So we're now in the process of doing that application, and the conversation doesn't stop at this point. The merger is very much the start of the journey, and whilst we talk about becoming a strategic commissioner, in reality that's several years away. There is a lot of work for us to do to get to that point. That means changing the way that we commission services as well, developing place, and actually what we want to be able to do is do that consistently across Coventry and Warwickshire, and we want to engage our stakeholders such as yourselves as we do that. So we are still very much in the stage of forming our plans for the next stage, but coming together as a single organisation and a single team is a significant step in us being able to undertake the work that we need to do with our staff and our stakeholders. So the next slide, please, Rose. So in terms of place, I've covered this before, and as somebody who works in place but also spends a lot of time doing system work, I can absolutely see how the two need to run alongside each other and are complementary of each other. And actually place is where actually the service transformation will happen. So at a system level, very much around planning what it is that we want to deliver, the outcomes we want to deliver. But in reality, the conversations about how we make that happen have to happen at a smaller footprint of place. And certainly my experience has been of that as well. So some conversations are just really difficult to have across the system, but certainly in South Warwickshire, it suddenly comes alive and you get a consensus around an issue when you're talking on that footprint. That's where the connections and things make sense. So it is actually places where 80% of the actual service transformation will happen. This is all about delivering integrated health and social care for our populations. It will be where the decisions about how the money is spent will be made. So in each place, they will be able to determine in the future how the money that they have can be allocated to different priorities, how they can shift money around the place in order to meet the needs of their population. And that's because we all start in a different place. All of our populations have got different needs. We've got different employment issues, we've got travel issues that are different. The solutions are not going to be the same across Coventry and Warwickshire, which is why place is really important. And we want to keep that kind of more detailed planning of services as commissioners and providers working together at a place level. And ultimately, it does support more effective engagement of our workforce, population and public sector organisations. Many of our third sector organisations tend to work in a particular area. Our district councils are absolutely critical in this as well. And actually, we can only effectively engage with those organisations if we maintain a place focus. So I think it's very much around place is going to be where all of the changes and meaningful in terms of what people experience services are going to, that's where the focus is going to be. And at a system level, it's very much going to be high level planning that takes place at that level. But in order for us to bring that alive, because I appreciate that might feel a bit abstract, I'm going to hand over to David and Jenny now to talk about what it actually looks like in reality and the progress that they are making in Warwickshire North Place.
Thank you, Anna. Could I just say to members, we'll take questions at the end of the presentation.
Great, thanks, Councillor Redford. So, hi everybody, I'm David Altringham. I'm the Managing Director at the George Eliot Hospital, but I'm here today as the Chair of the Warwickshire North Place Executive. And I'm accompanied by Jenny Northcourt, and Jenny is a joint appointment between Warwickshire North CCG and George Eliot Hospital, and her title is Director of Strategy, Service Improvement and Primary Care. And I think really important to kind of emphasise Jenny's role as a real having a real focus on place and being the person who coordinates all of our planning activity across the place. And we are really proud of the fact that we've chosen to make a joint investment in this in order to properly establish and lead place. And I also just want to mention a third colleague who was trying to be with us today, but unfortunately couldn't join us because of a clinical commitment. And that's Dr. Rachel Davies, who has joined the place executive as a GP leader and a primary care leader, and makes a massive contribution to the work that we do at Warwickshire North Place. And I think what I would like to just kind of emphasise again is the sort of degree of partnership and the relationships that are developing as we organise ourselves around Warwickshire North Place. We're having conversations that we perhaps wouldn't have had a few years ago because we've spent some time investing in some leadership and investing in relationships. So I'm going to emphasise that point as we go through the presentation, and important to start off on that foot. So just going to say a little bit about how we've organised ourselves at place, and then Jenny's going to take us through one or two specific pieces of work that we've been doing, including some work that we've done through the COVID-19 crisis across place, working together in partnership to make sure that we were doing the best that we could for the population that we serve. So Rose, if I could have the next slide, please. So this slide simply sets out a little bit of context. In the box on the right, there's a little bit of a profile saying something about the population that we are responsible for in Warwickshire North. We have 192,000 residents. It's a very diverse locality with a mix of urban and rural areas. There's a lot of development taking place with some rapid population growth expected over the next several years, and there are some high areas of high deprivation. There are also a number of areas with large BAME communities, and that is a real area of focus for us through COVID-19, which has had a disproportionate effect on Black and minority ethnic communities. And so that is a really important piece of intelligence for us, and is a really important focus for us going forward. In terms of establishing a place set of arrangements in Warwickshire North, we have no sort of legal standing or accountability as a place executive. We're simply a group of partners who've come together to work together to do the best for the population that we serve. And whilst that sort of structure is described in integrated care systems and STP structural diagrams, each organisation retains its own legal and statutory responsibilities, and so that sense of partnership and relationship is really important. The Place Executive was established just a little over a year ago, and we spent the first few months just really establishing an understanding of what each organisation in the health and social care system did. You can see on that list in the blue box on the left of that slide, a list of the organisations that are involved in the Place Executive. And it's fair to say that when we started on this journey, we had very little understanding of each other's pressures and what each other was responsible for. And that might come as a surprise, but I suspect that's quite a common theme. You know, the NHS and social care is a complex place to work. Organisations tend to be quite inwardly focused, so we've spent quite a lot of time trying to be much more external in our collective vision, understanding what our population looks like and what it needs, and understanding what role our distinct organisations play in the context of Place. And I can honestly say that the relationships in that room are in really good shape, and you'll hear about some of the great work we've done through COVID to respond together, which I think could only have been done in the way that it has been because of the relationships. I also want to emphasise the importance of the Warwickshire North Health and Wellbeing Partnership Group, and I know that several councillors who are in the room today have been involved with that group over the years, and Councillor Bell in particular continues to be a particularly strong supporter of the Health and Wellbeing Partnership Group in Warwickshire North. We've developed, I think, a really positive relationship with that group. It's chaired by Cherry Hutchinson, who used to be the Chief Executive of Warwickshire North Borough Council and is now the independent chair of the Health and Wellbeing Partnership Group. It sets the strategy for us, it helps us to determine our priorities, and we're about to move to a situation where the Health and Wellbeing Partnership Group also holds Place to account for delivery, and I think that's a really important relationship going forward and one that I want to emphasise. So moving on to the next slide, please. We've done quite a lot of work over the last 12 months establishing a plan on a page, and this is what the plan looks like. There's a huge amount of detail on there. I'm not going to draw you into the detail, but suffice to say that what we're trying to do is get to a place where on one side of A4 we can describe what we're all about, set out what our priorities are, and how we're going to develop objectives and delivery plans going forward for the year 2021. It lists our stakeholders, it talks a bit about the benefits, and if you kind of wanted a one-page reference to what Place was all about, that's where you find it. So that's why we've included it in the slide deck today, and I'm sure these slides will be shared after the meeting, so people will have that as a reference point. I just want to emphasise the point that it does put the patient at the centre of everything. And Rose, if you go to the next slide, we have turned that into a graphical representation, which hopefully you recognise as a common presentation across Coventry and Warwickshire, which initially was developed as part of the Year of Health and Wellbeing, but seems to have become the mechanism for communicating partnerships with patients and populations at their centre across the patch. And central to this are the principles of integration, collaboration and coordination, and that's what Place is all about. It's about working together to integrate services to give patients the best care that we can as close to home as possible, where patients only come to hospital when they absolutely need to, because we're working across the health and social care system, collaborating and coordinating our efforts to keep people at home, look after them there, and only bring them to hospital when it's not possible to offer them their care in any other way. And when we do bring them to hospital, that we do that for the shortest possible period, give them the best care that we can, and then get them back home again. So I just again wanted to draw attention to that diagram with the patient and population at the centre. The next slide is probably a little bit complex in terms of its presentation, but it just sets out how the whole wiring diagram works in terms of a connection between the Place Executive, the Health and Wellbeing Partnership Board, and the primary care networks that are really the front end of this, and which plug into neighbourhood priorities and a focus on really doing the best that we can to deliver those neighbourhood priorities that have been established. So I'm going to start at the right hand side of the diagram, if I may, and draw your attention to the green boxes there, which detail the primary care network setup that we have across North Warwickshire, with the Nuneaton PCNs, Rural North, Warwickshire North and Bedworth. The primary care networks wire into the structure through a primary care committee. There are a number of, what we've tried to do is not create additional bodies. So all of the things that you've got in front of you there, with the exception of the delivery assurance piece, which I'll come to in a minute, pretty much already existed in one way or another, but they all reported into slightly different places. And what we've tried to do is make sure that in terms of that spirit of collaboration and coordination, we've got a single point where each of those groups can come and talk to each other. The chairs of the groups are present in the Place Executive Committee, and it's where we unblock things that are getting in the way that individual priority programme groups haven't been able to resolve for themselves. So moving left across the diagram, you can see the priority programmes of work around wider determinants of health, long-term conditions, children and young people, mental health, urgent and emergency care, and community capacity and rapid response. And Jenny will talk a little bit about the kind of work that those groups have been doing to bring that to life in a moment. The government published through the Department of Health and Sir Simon Stevens the National Phase 3 recovery letter a couple of weeks ago around COVID-19. This takes us back into a recovery phase ahead of a complete reset of the NHS in April 2021. So this is kind of the operating plan between now and the end of the financial year in March next year. And one of the things that required was a reset board to be established. Because that's very operationally focused, we have put an additional group into place, and Jenny is chairing that group, and we'll be able to say a little bit about how that will operate in a second. And that will make sure that the detail, there's enough airtime for detailed discussion, but the Place Executive can focus on its job of hearing reports from that group, holding people to account for delivery, setting strategy, and then being accountable in its own right, both into the integrated care system and into the Warwickshire North Health and Wellbeing Board. And I think it's probably important to just say that you won't see the CCG referenced as an individual entity on that slide. They sit as part of the Place Executive Group. And in terms of just wiring this back into what Anna said, we anticipate that the role of a merged CCG will be much more strategic. They will sort of hold the purse strings and devolve resources down into place for us to make decisions about how we use those resources to deliver a set of strategic outcomes that will be defined by the CCG. And this is the engine room and the mechanism through which we will deliver that down through the groups that I've described and into the primary care networks, which are the front end of this and very much around the interface with our populations in primary care. So I'm going to hand over to Jenny now, who is in a car somewhere. So hopefully we'll be able to talk to us. Jenny, can you take over? I'm all prepared to carry on if she can't, but it'd be great if she could join us.
Thank you very much. Yes, I am here, and just to explain why I'm in a car is just because I'm between healthcare appointments for my son, so living the experience as well as being part of the team delivering the services. So, right, Rose, if we could have the next slide then, please. So from a place perspective, we very much took on board the fact that we're in a context of the system where, as a Coventry and Warwickshire Health Partnership, there'd been sort of three kind of key aims identified around healthy people, stronger communities and effective services. But we wanted to translate that for place in terms of with an understanding of our JSNA and what our JSNA was telling us, and also build on the stakeholder engagement that had been done through the neighbourhood JSNA work. So the JSNA has been a strong feature in helping us to determine the priorities that we need to work on, and the things that were reflected in that plan on a page for our initial focus. We've also looked at public health data to help drive our thinking in terms of where we need to focus, in terms of what's driving some of our health inequalities and what's driving some of the presentations in terms of health need, and the implications for the wider determinants of health and social care implications that actually sit alongside people's health and well-being, and that's been a key feature. And again, it's something that the Health and Wellbeing Partnership Board group has been really challenging us to ensure that we make sure that we cover in our priorities. We've also wanted to draw on what our population has been telling us about the services and the services that they receive. As individual organisations, we have all done various engagement, and one thing that our population constantly tells us is that we should not reinvent but utilise the intelligence that we've gathered, and so we've taken that very seriously, and we've pulled together the various engagement pieces of work that had already been done through some the planned care engagement, the children and maternities engagement, when we looked at the urgent care access requirements, and the out of hospital programmes that had been done, which was specifically in Warwickshire North for that contract, and tried to pull that intelligence together into one place and sort of take out the key learning and messages and feed that through into our work streams. And also the intention is to work very closely with our Health Watch colleagues, and we've recently had meetings with Health Watch to explore how we utilise the intelligence that they've been gathering through the period of COVID, and how we ensure that that is reflected in our planning and service developments going forward, and how we have a strong engagement in our governance arrangements going forward without it being tokenistic. So we want representation within the governance framework, but we also want it through the work streams by utilising the intelligence that we've gathered, and we'll continue to gather through those engagements. We have therefore set about pulling together all the comms engagement leads across the patch that will work with us, and that will be important both in terms of ensuring that as we take forward our work streams, we feed that intelligence into those work streams, but also that we can act collectively in terms of understanding the broader needs as people experience them through various different services. And that's been led by Stephen O'Hanlon, who has been working within the CCG and is coordinating our place engagement for the plan. So ultimately, we're trying at place to work together, wiring things up, seeing what's possible, moving things forward where we can pragmatically and on the ground, and then also identifying the priorities where we need collective action to do something different to actually address the issues and challenges that we face locally, understanding our local needs, our local context, our local workforce. And what we've found from a partnership point of view, which I think is really reiterating David's point is, and Anna's point, is that our that are connected to the area and have service responsibility for the area, and come together to say what problems are we trying to solve and how can we collectively contribute to those. The ability to innovate and to work beyond problems and around and through problems has been incredible, and has particularly been evident during the COVID period. So in terms of our priorities, what we've agreed that we are going to focus on are a number of areas, and those are listed on the slide that you can see from 1 to 6. And what we are looking to do is looking what's the added local value that we can really drive forward under those work streams, and bring together some improvements. So, for example, in urgent and emergency care, and looking at admission avoidance, and also in terms of looking at supporting access. We are already working with our out of hospital colleagues to look at how the primary care assessment in the community can link together better with our primary care network offer, and with our extended access offer in terms of GP capacity, and how we can wire things together with the hospital in terms of support with something called Consultant Connect, so that we don't always have to have people coming into the hospital, but we can give advice and guidance to support people to be dealt with through their community offer, and we can have rapid support. We've also been looking at discharge pathways and how we actually work with social care colleagues to support that, and how we do that locally, and how we do that follow-up in terms of more integrated care. In terms of long-term conditions, looking at our local population, and partly driven by the Health and Care Partnership and the JSNA, we've seen that diabetes was a clear area of focus, and also obesity is something that we want to particularly focus on, and obviously the two things can be related. And so that gives an example of where we've taken a specific local population approach in terms of identifying a focus for collaboration in terms of some specific conditions that we want to work through. And within that work stream, we're looking at the different pathways that can be developed through the primary care networks, with different types of workforce coming on stream. And an example there is in relation to MSK, where we're actually working to jointly appoint between the networks and George Eliot new workforce to support us in terms of first contact practitioners that will support additional capacity in primary care to deal with those sorts of conditions. Similarly, we've worked with South Warwickshire Foundation Trust and primary care networks to do some joint recruitment for clinical pharmacists that will be working in primary care, but will be employed by South Warwickshire Foundation Trust, who are going to be hosted within the local place-based teams and be part of the MDT, the multidisciplinary teams that are coordinating care and supporting patients around their medication management and providing that input. So those are some examples of some collaborations that have happened already and are in further development, which will increase capacity in primary care and community, increase integrated joint working to support long-term condition management. An example from mental health in terms of how we've linked the system to the local is the CWPT as the organisation sort of leading on mental health presented to us their plans from a system level in terms of mental health at the executive board, and following on from discussions of knowing how important mental health issues are locally for us and some of the challenges that we've experienced locally, which came up both through the Health and Partnership Board and also through the JSNA. And we were really keen to see some local input into our primary care networks, working alongside the out-of-hospital place-based teams to really enhance the support around the link worker mental health liaison offer. And through the negotiation, there's going to be a focus, and there will be capacity deployed into each of those networks, and that's in the early stages of being taken forward and being implemented, and we'll start off in the Rural North network firstly. Why determined obesity, and that actually came out of is very sort of new in terms of being added to our priority focus, in that we had a partnership group away day, virtual of course, in the dances, where we were looking again at the JSNA and the wider determinants of health. We had a session that was led by public health and the local in terms of that discussion, and Yasser, who is linked into the Health and Wellbeing Partnership, led that discussion. And following on that discussion, we felt that we needed to really focus on, and that's been a commitment, and we'll be working up those proposals with that focus. In terms of community capacity and rapid response, here the example that we can talk about is the fact that during the COVID period we managed to respond, develop and enhance our care home offer. So obviously there's a lot of things in the press in relation to to care homes, and we were able to work with our out of hospital colleagues and primary care colleagues and community pharmacists to further develop the offer to care homes, and working with the local authority as well to support some of the infrastructure around improving some of the IT infrastructure that's going into care homes. And we've recently also now agreed to develop a remote monitoring solution that will support care homes, linking in our GP practices, out of hospital teams and care homes to support with the inputs to care homes, and that's something that we're moving on to, and it's called Docabo, and it's a remote monitoring solution, and we're really excited about the opportunities that will help us to support and enhance further the support to care homes. In terms of maternity and children and young people, we've had a discussion about services for that cohort, and one of the things that we were challenged to look at again by the Health and Wellbeing Partnership was around smoking in pregnancy. And that was therefore then fed through into the report that was presented to the Health and Wellbeing Partnership, and that was fed through as a challenge to the executive in terms of what are we doing as a collective set of organisations to support some of the challenges that we face locally in seeing the rise in smoking in pregnancy and the implications that has for our for stillbirths and complications. And that's a challenge that we've taken up and is going to be a feature in our plan. So that gives an example of how the data, the needs of local people and the aspirations of our partners are being fed into the work that we're doing. Next slide, please. So I think hope that with some of those examples I've brought to life some of the benefits at place. I'm not going to read everything that's on the slides, but what I would really say is I think the benefit of local place working in this way is that rather than it being a relationship of separation of individual organisations, whether that's a commissioner or a provider, and depending on whether you're acute, community or primary care, what's happening at place is we're coming together and saying we have a collective cohort of patients and citizens that we have a responsibility for, and we understand some of the needs that they have, and that we want to work collectively to take work forward together to make the best of our shared resources and move them forward. And ultimately we share the desire of achieving those I statements that are at the bottom of that page, and we've adopted the I statements and tweaked them for our place that have come out of the strong National Voices engagement, which was a large national engagement piece where individuals and service users were asked what was important for them in terms of what they wanted to see from integrated care. Next slide, please. So I think I've already covered the examples of what we're doing, so that's just sort of reiterate some of the things I've already mentioned. So you've got that on the slide pack when it's shared with you, so I won't reiterate that, but I think it's really just things, and that's what we're trying to do for our population from our collective resources, and I think those are really good examples of how we're already starting to achieve that. Next slide, please. So an example of something that happened during the pandemic was the way we worked together on providing hot hubs, and this was really about providing support for people with COVID symptoms but that weren't needing to necessarily go into hospital, and it was a fantastic partnership really. We had property services that support us to identify premises and make them fit for purpose. We had resources shared with George Eliot in terms of staffing to help us deliver the service. We had primary care developing the protocols and setting up and establishing the actual offer. We had a direct line between primary care and the hospital to support joint working and decision making about pathways of whether people could be dealt with in primary care or needed to come into hospital. and we had great support from our hospital colleagues in terms of the single point of access, and support and advice and guidance in terms of utilising Consultant Connect for those individuals in need. And that was a fantastic collaboration that was pulled together during the pandemic. Next slide, please. I think I'll hand back to David at this point in terms of the key messages as chair, but hopefully that we've given you some sense of what we can achieve and how we're focused. And I think the key point is keeping it local and getting connected and working with people that feel directly involved with that patient population is really been the key to, I think, developing the partnership and creating the common purpose around what we want to achieve for our local citizens and patients.
Great. Thanks, Jenny. So just a bit of a summary slide, really. I think we've made a lot of progress, and if you'll forgive the pun, we're in a good place. We're really grateful of the support that we've had from the Warwickshire North Health and Wellbeing Partnership Board, and for the relationship that's developing there. That's really important in terms of keeping things local and keeping things real, and holding us to account for delivery in a way that we've perhaps not been held to account previously. The relationships that we've developed are key to all of this, and they're probably stronger than they've ever been, and strengthened by the experiences that we've had working together through COVID. Things are still emerging in terms of what will happen next. So we know that phase 4 of the COVID recovery plan, so we're currently in phase 3, just to remind, will potentially see some changes to legislation, strengthening the position of ICS. And we know that there's an application process in place, and we're likely to go in February through an application process to become an ICS, and place would be established as an entity as part of that process, we think. We've shared with you our key areas for delivery set out on a plan on a page, and to reassure you, we think that place is here to stay. We think it's the right thing for the population of Warwickshire North. Hopefully we've described how our relationship with the CCG will enhance rather than detract from that, and really all about that message at the bottom, helping people to help themselves, but being there for them when they need us. So with that, I'll hand back to the chair. Thank you, Councillor Redford.
Thank you. Thank you very much, David, and thank you to all three of you for the presentation this morning. Right, now I'm going to open it up to members for any questions, please. I was going to say silence is golden, but of course with our virtual, we've got one. Pam.
Thank you, Chair. I was just a little bit concerned on one of the earlier slides where we had the phrase opportunities to reduce costs of delivery are identified. Now, to me, that is the posh speak for look out, we're going to make cuts. Can I have a comment?
David, are you going to come? What I should do, David, is ask you to put the question to one of your colleagues or yourself.
Yeah. Okay, for sure. Well, I'll start, and if others have got a comment to make, I'm sure they'll join in. So the opportunity there is that there's quite a bit of duplication in the system as we currently have it, and there's an opportunity for us to be more efficient in the way that we operate. So perhaps a good example of that would be we know that a large number of people historically have come to the A&E department at the George Eliot Hospital when perhaps their care could have been offered in another place. And so for us, it's not necessarily about taking cost out. We will have a budget within which we've got to live, and we would expect as the integrated care system comes into place that would be quite clearly defined. So we'll have to live within that budget. But it's more of an opportunity to do things like move resources around. So the example that you heard of moving staff from the George Eliot into the community to prevent people from having to come to hospital meant that we were paying for a resource that was being deployed in primary care. And those are the kind of things that we think would make the system more efficient, because historically those patients would have come to the hospital. That was just not possible anymore. So working together meant that we were able to keep people away from hospital by redeploying those resources, and that's what that's all about. Adrian might want to comment about the budgetary issues and cash in the system.
Chairman, before you go, can I just to so your idea is to move staff out into the areas, and where are they going to go? I mean, are you going to set up medical centres, or are they going to be distributed to the local GPs?
Yeah.
How is that going to work?
So, so if you think about things like we talked about people with musculoskeletal disorders, so people who might have sort of hip or back pain or something like that. Again, historically, we might have brought some of those people up to hospital, and that's kind of a waste of their time, because we could probably deliver a lot of the things that we could do closer to home. So we've made some decisions to invest in first contact physiotherapists who will be employed by the George Eliot Hospital, but will work in GP practices. GPs will make a referral to them. They'll be based there. So instead of the patient having to come up to the hospital, the professional will see the patient in a GP practice or another facility. And it's kind of things like that we think will be more efficient for patients and will reduce cost in terms of patients coming to hospital for things that they don't need to come to hospital for. Does that make sense?
Thank you.
Providing that all the GPs have sufficient facilities to accommodate these people. You know, I mean, some GPs, I know not many now, but still some are single practice GPs.
Yeah.
That equates to quite a very small surgery. So,
yes. Absolutely, and it's kind of bite-sized chunks, so there'll be places where we can do this quite quickly, and there'll be other areas where we kind of might need to plan a little bit or use different solutions. But you know, a lot of this stuff doesn't really need to be done in proper clinical space. It can be done in other buildings. So there are facilities across the patch that are run by the community services and facilities that are run by the local authority, and you know, a lot of those would be suitable for seeing some of these patients. So I think we've got to get creative around some of this stuff.
Okay, David, thank you.
I
Margaret?
understand that. Yeah. Okay.
And just add one thing as well, and it goes back to the point David said right at the start. Really, when we're discussing these solutions now, it's everyone sat around one table. So you would have Rachel Davis as the GP in the PCN chair. You'd have the acute hospital. You'd have Jenny in it. So we are trying to kind of get everyone around the table to get the best optimal solution, and not shouldn't between organisations, which may have been a feature of past ways of doing things. So, you know, the GP will be at the table discussing that solution.
Thank you, Adrian. Margaret.
Thank you, Chairman. I would like to say thank you very much for this presentation. I think you've put a lot of work into it, and it's been really, really useful. And at the end of the day, for me, the bottom line is that the health outcomes improve and the health inequalities reduce. That's basically where we all want to get to. So that should be the overall objective, basically, for everything that we do. So, and I have to say, you've sold Place really well. And there's some really exciting work going on in Warwickshire North, and thank you very much for what you're doing. I think it's brilliant. There's just one thing that's not on the list, and it'll be coming through from the partnership board to you, and that's end of life care. And it's been on our agenda for a while, and we don't want to see it go. So that would be fantastic if you could add that. The thing is, you've sold Place so well. I am left with the question: why have we got to go to a joint CCG? Why don't we leave it at Place? Because you're working so well together. Now, I'm just going to say, can I hear a little bit more about what the joint CCG, what are the benefits of the joint CCG overarching these really good stuff that's going on at Place? And I'm sure there are, but I know this was focused on Place, but I'd like to hear a little bit more about what are the benefits of joining together, as it were, at the top. And on that point, the critical issue always is funding. So I assume what's going to happen now is that all the different funds that went to the different CCGs will be pulled together, basically, and then allocated. So on what basis, what criteria are going to be used for that allocation? And is it a situation where something like Warwickshire North Place will have to bid for funds for the things that they want to do from that central body? I'm not sure how that's going to work. We all know we've got health inequalities, and they're not. We've got lots in the north, but they're not only in the north. There are other types of health inequalities across the piece. And how are they going to be addressed whilst also satisfying everybody's funding needs? And those are questions I'm left with. So that's really all. I just need a bit more reassurance now, because I'm really pleased with the place that's going on. Now I need to know what the central bit's about. Okay, thanks very much.
Thanks, Councillor Bell. So if I just pick up the end of life care thing, so message heard loud and clear, we'll take that back and make sure we don't lose that. And perhaps Adrian or Anna would like to come back on the questions that you've asked about the CCG merger.
So I'll start off. I'm sure Adrian will follow. I think one of the challenges that we've had with the three CCGs working separately is how do we coordinate activities across the whole system? And it isn't the majority of things. It's if we're thinking about how we plan cancer services, how we coordinate capacity across the whole system. So COVID is a really good example, and conversations that were live yesterday, which were if we have a surge, how, if UHCW is taking that surge, how do we make sure across the system that we're able to maintain elective activity, to maintain equity across all of the Coventry and Warwickshire system as well? So it is really about that coordination between places, because the risk is that the four places could be doing great stuff individually, but how do we hold it together to make sure that in overall terms, from a Coventry and Warwickshire perspective, we're improving outcomes for everyone, and that we're able to identify the opportunities where we do need to work together? Because if we're planning services like cancer, maternity, neonates, stroke would be a good example, there needs to be a coordinating function. And if I'm being honest, working in one of the three CCGs, it doesn't work that well when we're working as three CCGs. And actually we do need that single voice into the system. We need to be giving a consistent message to our providers, and also from a local authority perspective, I might be talking, they might disagree, but I doubt it, is that actually from a Warwickshire County Council perspective, having three CCGs who want to do things slightly differently isn't helpful for Warwickshire County Council as well. So it gives us a real opportunity as well to think about those joint commissioning arrangements, because actually it's less organisations in the mix. It just simplifies things. But as you said, it is all about place, and it's about how do we kind of, in essence, do the planning at a system level, allowing that in order to make things more efficient and make sure that we stay connected and how are consistent in outcomes across the four places. But really the work is at place. So it is about becoming a much, I suppose, a smaller, streamlined strategic organisation. And a lot of what we do as CCGs will continue to happen at place.
Thank you, Anna. Okay, Margaret.
Can I have an answer on the funding issue, please?
Yeah, and a couple of points just to add over and above what Anna said, and Anna's made all the points I'd have said. The other tricky one is, we do know we've had our running costs reduced by 20%. So the amount of money we have to save in order to keep the CCGs going has been reduced by 20%. And ultimately, we have a choice about whether we take that out of very senior accountable officers, governing bodies, finance departments, or if not, we take them out of the people like Jenny and Jenny's team and those that support place. And so, if we didn't do it and had to maintain three governing bodies, the amount of support going into place would be significantly less. And that's just a matter of fact of when you have to reduce your running cost budget by 20%. So I think when you say how do you keep place going, we wouldn't be able to keep place going in the same way. We'd have to take 20% of our resource out from the very teams that are supporting Warwickshire North and the other places, and that's a tricky message to take, but it's the reality. In terms of the allocations by place, I think, as I said last time, this was a question that came up very much from our membership when we did the votes, very much the GP practice, and there's a commitment to keep the allocations were previously notified for each individual place in each individual place, so those won't be altered. I think there's another thing in terms of additionality of money as well, and so I've certainly noticed that when the national team are looking for test sites or areas to put money into, what they're looking for are systems that are coterminous with their STP or ICS, and when you're in that position you can get additional funding. So right at this very minute we're working with some of the PCNs and the national team around personalised care, potential for sort of £500,000 coming in that just wouldn't come into us if we weren't planning to merge as a CCG and they had to dish it out between 3 individual CCGs and that. So it puts us in a really good place to kind of say, as a system, we're joined well together. As a system, we're sharing best practice across places, which I think is also important. David was on a meeting yesterday with me, and we were talking around endoscopy across there, and all 4 places were starting to say, well, actually, we could do this. We could do this a little bit better if we work together. And I think the system and the strategic commissioner has a role, which is how do you make sure that whilst doing 4 places, you're also sharing and getting best practice and not reinventing the wheel every time. So there's some of the things that I think that the strategic commissioner can do. But I will come back to that. If we have to take 20% out and we can't take it out from the overheads and the senior bits, then what we are going to have to take it out from is the people support in place, and the very people that are going to lead the end of life challenge and the obesity challenge and all the stuff that David's talked about.
Thank you, Adrian.
Thank you. Thanks very much.
Thank you, Margaret. Les?
Yes, thank you, Chairman. Just to support Anna and Adrian, I was doing your role when 3 CCGs were formed. Warwickshire never wanted 3 CCGs then, and the late Bob Stevens, bless him, was doing my role. We always wanted 1 CCG, and we've always supported the move and fully supported the CCGs moving to 1 now, and exactly as Anna has described, exactly right. So I do want to thank everybody for the excellent reports, but to go back to your excellent diagrams, to the layout that David dealt with first, you've missed out Warwickshire Health and Wellbeing Board, and all 3 place forums report to Warwickshire Health and Wellbeing Board before Coventry, before the joint place.
Yes, you're right. We'll correct that. So we do have a pretty diagram that brings that to life, but you're right, it isn't on this diagram. That is the statutory body, and we do absolutely appreciate that. That's where the local health and wellbeing board reports, Les.
But I do thank you for what you've achieved and where you've got in North Warwickshire. You are in an excellent position, and more strength to your elbow. Thanks very much.
Actually, Les, just looking at that diagram, I think the Health and Wellbeing Partnership Board is perhaps reference to that Coventry and Warwickshire group, but
that's
it's not. It's not clear on the diagram, so thanks. No. We'll correct that.
Thank you, David.
The system is the 2 health wellbeing boards, and then that above, which we all work together with, which is working excellently as well. And well done, everybody.
Thank you, Les. I have Judy McDonald.
Thank you, Chair. First of all, thanks for a great presentation, really informative. And as a clinician, obviously, I'm so pleased to hear of all the things that are happening to meet local need. I suppose one of my concerns is the joined upness between system and place, and making sure that the strategic decisions that are made at system level really reflect what needs to happen at place. And we've had such a brilliant presentation on place. I don't know whether I'm missing the point, but I could have done with a similar one on the pros and cons of the system and what's proposed there. Just one other comment, that earlier on in the presentation you referred to improved recruitment and retention. It just feels like the people in that single CCG might be almost a different breed or whatever, because there's surely got to be less local engagement with a single CCG. And some of the recruitment and retention of strategic and clinical type staff is that local engagement often. So it's really just a comment.
Okay.
But thank you.
Thank you.
Thank you very much. Thank you. Now, are there any other speakers? I haven't got any at the moment. No? Okay, well, oh, no, Chris Bain.
Yes, it's just, thank you, Chair. It's just my usual plea for patient voice to be lodged in this system. I was listening to what David said about a process to establish the ICS by February. And for me, that's a sort of deadline for us to hardwire patient voice and accountability to patients within the system. Because once the system is set and once it's been agreed, it's really hard to do it retrospectively. And I think, and I see David nodding, because David and I have discussed this before, haven't we?
Yeah.
And I think that is a deadline by which we have to get these processes for patients to have their voice properly heard. And another plea from me, please, to get inequalities, I think, more high profile within the new ICS. The objectives that were set out so clearly by Margaret Bell to be hardwired in as well. Thank you, Chair.
Thank you, Chris. Thank you for that. Anybody else? Any questions? No? Okay. Well, just my personal thanks to the three of you for that excellent briefing. I really think it did cover all of the points that were raised at our previous meeting. Now, for the members of the committee, referring back to our meeting on the 30th of July, we were asked, the committee was asked to support the proposed changes in the structure of the clinical commissioning groups in Coventry and Warwickshire. So I'm going to ask the committee for its support. If you are not prepared to support it, would you indicate? Otherwise, I shall assume that you will support the changes. So over to the committee. I'm looking for anybody who is not does not wish to support the proposed changes. I haven't got any. Paul, have you got any?
I can't see any hands raised, Chair, if that's what you meant. So people raising a hand to show anything other than acceptance.
We shall not prolong the agony. So the recommendation goes through as I have just read. And once again, thank you very much to our presenters for coming along today and giving us the time to answer all our questions. Thank you very much indeed. And to the committee members, thank you all for attending. If you can hang on, Margaret.
Thank you very much. Bye-bye.
Bye.
Thank you, Chairman. Well done.
Thank you.
Very much.
Bye.
So, Chair, if we could just have a few moments. Anna Hargrave, Councillor Clifford, Vicky Castry.
That was brilliant.
Thank you, Joe.
Much appreciated.
I think we're down to the three of us, Paul.